My name is Maeve Eogan and I'm a consultant obstetrician and gynaecologist at the Rotunda Hospital. In addition, I'm the National Clinical Lead for the Sexual Assault Treatment Units. So the first Sexual Assault Treatment Unit in Europe was established here at the Rotunda in 1985. It was established by the then master of the Rotunda Hospital, Dr. George Henry, who had gone on a lecture tour of Australia and had encountered a sexual assault treatment unit and really felt that that was perhaps a gap in our service for people in this country. And he came back and, with the support of the board of the Rotunda Hospital, established the first sexual assault treatment unit in Ireland here at the Rotunda. The unit has been running with continued service since 1985, and indeed the sexual assault treatment unit services around the country have been established because of the Rotunda service. People saw the Rotunda service, and although the Rotunda reached out and looked after people from anywhere in the country, it was obviously felt at a time of immense personal crisis it's not appropriate for somebody to have to travel from Cork or Donegal or Galway or Waterford to the Rotunda for sexual assault treatment unit care. So there are now 6 units around the country in Dublin, Waterford, Mullingar, Cork, Galway and Letterkenny, meaning that nobody in this country is more than 3 hours from their nearest sexual assault treatment unit, and meaning that people can access care around the clock, 24 hours a day, 7 days a week, 365 days a year. And that care is available regardless of which unit they present to. The care is the same according to national guidelines and standards, ensuring that people get the right care at the right time for based on what has happened to them and what they require. So the care that's provided within the sexual assault treatment units very much depends on what the person needs at the time. The care is extended to men and women. There is no gender restriction on attending the sexual assault treatment unit, and the care that we provide depends on what the person needs. About 2/3 of the people who come to the sexual assault treatment units come following a referral from An Garda Síochána, and indeed are brought to the sexual assault treatment units by An Garda Síochána. And they are people who've disclosed an incident of sexual violence to the police, and a police investigation has begun. As part of the police investigation, the police will want us to have forensic samples. So those samples are taken here in the sexual assault unit. So they may include samples of the patient's hair, samples from under their fingernails, and indeed intimate samples, samples from the vaginal area, and samples indeed from the back passage, depending on exactly what has happened in terms of the incident that the person has disclosed. In addition to that forensic care, which is obviously a really important piece of what we provide in the sexual assault unit, we also provide supportive care. So that includes physical support, so things like emergency contraception, medications to prevent infectious diseases, and indeed an assessment to see does somebody need medication to prevent them acquiring HIV, for example, after an incident. And in addition to that, our colleagues from the Allied Rape Crisis Centres provide psychological care. And that's obviously a huge part of anybody who comes to a sexual assault unit. There is nobody in the world who expects they're ever going to end up in a sexual assault treatment unit. So when people come, they firstly have to adjust to the very fact that they're here, on top of the fact that something has happened to them which has required them to be here. So there's a huge amount of supportive care available to people depending on exactly what they need. Some people might want to talk to someone from Rape Crisis for a long length of time while they're here in the SATU. Other people might just want to take the details of the Rape Crisis Centre so that they can acquire that supportive care afterwards. And some people might need a blend of both. But very much within the sexual assault treatment unit, we have an ethos of providing exactly what the patient needs at the time. All of the care is free of charge. There is absolutely no cost for the patient associated with attending the sexual assault treatment units, and we try very much to be a very responsive service, providing, as I say, care around the clock in order that somebody can come to us proximate to when the event happened, because DNA evidence does deteriorate quickly. So unfortunately, while somebody may be exhausted, may be very stressed about what's happened to them, we do encourage them to come as soon as possible after the incident, particularly in the context of when forensic evidence is being collected. We want to see people in a really timely fashion in order that we can optimise the forensic samples that we take, and indeed in order that things like emergency contraception and infectious disease preventative treatment have the highest chance of being highly effective. So since 2009, we've been collecting national data from the 6 sexual assault treatment units. And in the last 4 years, we've been very fortunate that we've have had a web-based data collection platform, which means that each of the units inputs their data into this web-based data collection platform. It's completely anonymized data. There's no patient information, but there are just metrics about the specific patients in order that we can determine what are the care needs of the patients who come to the sexual assault unit. Is the service appropriately responsive to the patients that we're meeting? So this web-based, centrally accessible or centrally hosted data collection platform has been really useful for us to identify trends and metrics. And indeed, since 2009, we had been seeing an increased number of patients attending the sexual assault treatment unit year on year. And indeed, for the first 2 months of 2020, prior to COVID reaching these shores, we had a 6% increase in the number of patients attending in the January-February 2020 compared to January-February the previous year. And certainly when COVID happened, there was a change. Sexual violence unfortunately didn't go away, but the number of presentations did reduce. Overall in 2020 we saw 22% less people than we would have seen in 2019. Now, if you're an optimist, you can say that's because sexual violence reduced during the COVID pandemic. Obviously, if you're a pessimist, you can say, was it that people weren't attending? Were they afraid to attend? Were they concerned that the restrictions meant that they couldn't attend? So certainly that's something that we need to look at. Different things that we saw was during the period of the COVID pandemic, and particularly in those early 6 or 7 months, there was a changing face in the spectre of sexual violence. It didn't disappear, but people were more likely to come disclosing an incident that had occurred with somebody known to them, so an intimate partner or a friend, rather than a stranger or a recent acquaintance. We saw less college students, perhaps because the colleges had all gone online, but there were some concerning things. For example, we saw a slightly increased representation of people who disclosed that there had been a threat used in the context of the sexual violence. So that's concerning. You know, were the incidents a little bit different? Were the incidents more threatening? Not that sexual violence is ever an unthreatening spectre, but there were changes that were seen. We didn't actually see a reduction in the number of people who had attended with An Garda Síochána, so there was still the same number of reports to An Garda Síochána who came to us. So still 2/3 of our patients in 2020 came with An Garda Síochána. The other pathways that people will use to access our care are, some people will come just looking for a health check. They don't want to report the incident to An Garda Síochána, and provided they're an adult, that's a choice that they absolutely can make. They can still come to the sexual assault unit, access emergency contraception, and access infectious disease preventative treatment, and of course psychological support. The third pathway for coming to the sexual assault unit is to have evidence stored. So someone who's unsure whether they want to report to An Garda Síochána, but they're aware that DNA evidence deteriorates quickly. So while there's no statute of limitations on sexual crime, somebody can report an incident that happened 20 years ago. Obviously, the benefit of them having evidence stored here is that if they do wait a month or 3 months or 4 months to report the incident to the police, the fact that we have the DNA evidence here means that that can be processed and used then by An Garda Síochána as part of the investigation. So those 3 pathways continued to be accessed throughout COVID, with, as I say, the Garda pathway being the more frequent one, but both storage of evidence and health checks continued to be provided. We did enhance our social media platforms. For example, the HSE website was further developed to provide some videos on what happens in an SATU, a sexual assault treatment unit, and how to access a sexual assault treatment unit. So even though people weren't in college, say weren't, for example, meeting a college supervisor who might be able to tell them about a sexual assault treatment unit, they could, through social media and web-based information systems, be aware of the service and aware of the fact that despite COVID, the service was still existing. We had to institute some changes in order to keep patients safe and to optimise staff safety. So we instituted a COVID symptoms questionnaire, for example, to ensure that people weren't symptomatic before coming here. And indeed, if they were symptomatic, we arranged urgent testing for them. So we tried not to delay their attendance by any significant length of time. Furthermore, we instituted initially some telephone interviewing. So when somebody would arrive first, there would be a phone call into the waiting room from the SATU team to get some of the history-based pieces of information to ensure that the face-to-face time was reduced. That was difficult because the patient who was coming to the SATU was meeting, or was only having this phone conversation initially with the forensic examiner. So we were lucky to secure funding through the HSE for 2 iPads for each sexual assault treatment unit. And that meant while we were still limiting face-to-face contact, that initial history still had a feeling of a face-to-face consultation because of using video phone calling capability. So that was good. As vaccination rates increased, while we were still careful to limit the duration of face-to-face contact, we could move more towards seeing people face-to-face for the duration of their history taking rather than just for the examination. And we have good ventilation in most of the sexual assault treatment units. Even though they are small areas within hospital settings, we have good ventilation, so that enhanced the safety and meant that we could reduce the risk of any concerns about COVID acquisition within the SATU. So the main challenge with provision of SATU care is based on the fact that it's a 24-hour-a-day, 7-day-a-week, 365-day-a-year service. And obviously you have to have sufficient staff in order to provide that care around the clock. Furthermore, it can be a stressful working environment, so you certainly don't want that care provided only by 1 or 2 individuals. You want to ensure that your rota is such that people have work-life balance while working in the sexual assault treatment unit, but that patients can access that care when it's needed. So that is a challenge, and we are really lucky to have improved our staffing levels over the last decade or so, primarily due to the funding of the clinical nurse specialist and advanced nurse practitioner role within the sexual assault treatment unit. So this is a group of highly specialist nurses and midwives who have undertaken high-level training in provision of SATU care. And each of the sexual assault treatment units around the country, while they have a blended team, so there are doctors involved in provision of care as well, each unit has a core group of specially trained nurses or midwives working as clinical nurse specialists or advanced nurse practitioners in order to provide a 9 to 5 Monday to Friday consistent staffing level within the sexual assault treatment units, but also providing the on-call staff in collaboration with the specially trained medical staff as well. The other challenge of provision of SATU care is that most people don't know that SATUs exist until they need them at a time of immense crisis. And when they need them there and then, and they need them to be responsive to their needs. So the SATUs are often noticed more for their absence than their presence. Even in our busiest year, together, the 6 sexual assault treatment units just saw about 1,000 patients. So when you compare to emergency departments or labour wards or antenatal clinics, really we're seeing a small number of patients. But though each and every one of those patients needs our service. And Consequently, it's so important that we continue to advocate for appropriate resourcing of the sexual assault treatment units and appropriate development opportunities within other clinical and strategic developments that are happening within the health service. And that's why it's really valuable that the Health Service Executive have appointed a national clinical lead and indeed a national team under the governance of the National Women and Infants Health Programme, in order that the sexual assault treatment units hold a place in the Irish Health Service and don't disappear or don't become defunded because of other significant demands on clinical funding.